End like this, and thank you.
Thank you, Dr. Abu Rahma. Next is Professor Jamal Hoballah, speaking to us about the management of central venous stenosis in hemodialysis patients. Professor Jamal.
Thank you. Thank you, Mr. Chairman. My presentation is on the management of central vein stenosis in dialysis patients. What I'd like to do is to go over some of the pathophysiology and review some of the endovascular and surgical treatment options. Now, the incidence of this type of pathology is about 4.3% and goes up to about 6.8% in patients who have had prior history of catheter use. And some of the independent risk factors for the development of such a pathology is prior catheter placement and total number of catheter placed, the presence of pacemaker, and younger age at the dialysis initiation. So the mechanism of obstruction typically can be related to reaction to the indwelling venous devices. It can also occur without any prior indwelling devices and also can occur due to external compression. Now, the indwelling devices, cannulization of the subclavian catheters, like having long-term catheter in the subclavian, is associated with some of the highest incidence of this pathology, followed by internal jugular. Clearly, using short-term dialysis catheter longer than needed is associated with increased risk of developing such pathology. PICC lines can also cause such a problem, prior use of PICC lines, and pacemaker and ICD devices. And I will go to that the pacemaker, they cannot underestimate it, up to 25%, and that incidence can go up to 50% or more with the more complex ICD devices. Now, in those who have it without indwelling venous catheters, it can really happen, and especially if you have a proximal permanent vascular access with a very high flow rates. This very high flow rates cannot be accommodated by the existence venous outflow, and as a result, it will cause a reactive hyperplasia in the central vein. Now, the other ones, the external compression, they can be anywhere, anything from ectatic aortic arch to a costoclavicular junction compression. Now, the presentation can be typically edema and swelling on the ipsilateral side with some venous hypertension changes and even some skin ulcerations in the upper extremity. You may even have swelling of the shoulder and face and the chest wall. Another type of presentation will be excessive bleeding from the puncture sites along with cannulation difficulties, and you can have a megafistula. This is an example of a simple one, but this is as it gets more complex. And this is an example of a megafistula. Now, what's the treatment? The treatment options you have, first of all, if you identify an asymptomatic central vein stenosis, studies showed that if you go ahead and intervene on those, that leads to a rapid progression of the stenosis and a further worsening of the situation. So prophylactic treatment is typically not indicated. How about the symptomatic ones? The symptomatic ones, you have the options of endovascular or the surgical options. Balloon angioplasty, stenting, these are the options. Now, how about between surgical options and endovascular options? Well, there were some studies showing that they have comparable results. So with that in mind, one would try to go always for an endovascular approach first. And with the endovascular approach, if you're dealing with a fistula, you are likely to have better outcomes than if the primary situation is a graft, and especially if the patient has not had prior catheter placements. So what are some of the issues with the endovascular treatment with angioplasty? The response to angioplasty, you can have an elastic or a non-elastic. So you can have a good number of them, almost about 60-70% that will have an improvement after the balloon angioplasty alone. But you're going to have about 25% of them who are going to have an elastic lesion that will not respond or will fall apart. And then of those elastic lesions, most of them will typically occlude. But if you place some stents in them, they seem to have a longer duration of patency. As such, vascular stents can be reserved to those lesions that show elastic recall after the angioplasty. Now, that brings us to the situation, should you do routine primary stenting versus TPA? And clearly there was no statistical difference between angioplasty alone and primary stenting in several reported trials. So, and the long-term results of the angioplasty seems to be very durable, and the primary patency was significantly higher in the angioplasty group than others, although the assisted primary between primary stenting and angioplasty were equivalent. But nevertheless, that kind of gives us the conclusion that stenting can have the lower primary patency rate and should be considered in angioplasty resistance lesions. So in such, the typical indications for stenting will be non-responding lesions, recurrent stenosis, and elastic lesions. This is an example of a patient who had the pacemaker, and then you can see that he had the blockage at this level, and this is balloon angioplasty, and with the balloon angioplasty alone, we were able to save that fistula. This is another example of another patient who had a left brachiocephalic, and treated with the first balloon, gentle dilation, and then a larger balloon, but he kept on having a persistent stenosis, so he ended up with placement of a stent in it, and that resolved the situation. Another type of patient, and this one had a stenosis down at the junction with superior vena cava, which required ultimately stenting to maintain the patency. How about the stent graft versus angioplasty? Well, stent graft seems to be has a good patency rate, but you have concerns that you may jail important branches, and if you oversize, you can cause some blockage in it, and that's not a good option. How about paclitaxel and others? They seem to have some potential use, but there's no proof, as in the previous debate, that they are much better than the others. The surgical treatment, you have surgical treatment that involves the sternotomy to reach to that area and the extra anatomic one. Clearly, the sternotomy ones one would like to avoid because these patients are pretty sick, although there are new techniques that you can do it with a clavilectomy and mini pericardiotomy without a sternotomy, but that's still not a very likable situation. And they tend to have pretty good outcomes ultimately with good patency rate, but most of the situation you end up trying to do something that's extra anatomic, a bypass from the axillary to the jugular, axillary to the contralateral jugular, or even a turn down of the jugular vein into the axillary vein. So depending on what the anatomy you ultimately can do, or a basilic vein to the dialysis. This is a procedure that I did at the University of Iowa, and you always hear Dr. Nazal saying that he trained with me, and everyone doesn't believe it because I look younger than him. But having said that, this is a proof that we worked together, and this was back in 2000, more like 20 years ago, and this is the technique that we use on that case. Another technique that I really would like to remind you of is the axillary bypass. It can be done under local anesthesia, and this is an example of a case that we ended up doing that to her. And basically now she has a patent fistula. You can see the incisions here. And I did that 2 days ago, the duplex on her, showing good patent flow. And the final procedure, if all of those fail, then you have the option of doing precision banding procedure if the access has a high flow. So if the access has a high flow, you can do banding of the fistula, and that would lead you to a patency, and you can maintain access salvage and do with that. So in conclusion, these central vein stenosis are amenable to endovascular therapy. The surgical bypasses are reserved for obstructions that are not corrected by the endovascular means. Extra anatomic veno-venous bypasses are ideal when you need to do a bypass, and if all fail and you may have to do something, you can consider flow reduction in select patients with high flow fistula. I want to thank you again for the opportunity to be here with you. I want to remind you, we are all invited to Riyadh in 2 weeks from now, and for those who could not make it this year, please realize that we are set, inshallah, for next year in December in Riyadh, and hopefully you will be able to meet us. Thank you very much for your attention.
Many